As a kind of introduction, I will tell you a little bit about fetal surgery, because there is not many reasons to do surgery before birth. Most of the congenital malformations we diagnose prenatally can be managed safely and effectively after birth. But some of them either lead to fetal death, which is uncommon, or can cause irreversible damage to the fetus that makes their management after birth either difficult or meaningless. So for those conditions that we can diagnose before birth and that we can on an individual basis predict the poor outcome in that particular fetus, and there is a surgical solution before birth that has been shown effective in experiments and in early clinical trials, those can be considered for surgery before birth. The eldest indication we will discuss is the treatment of pulmonary hypoplasia, which can be in the context of urinary tract obstruction, for which we still don't have a solution, but as well for congenital diaphragmatic hernia. The other conditions are treatment of twins, for which there is no level 1 evidence that it can be treated in utero. As I told you, diaphragmatic hernia, but also recently to that list of indications is a non-lethal condition, which is spina bifida. So the first surgical target, this lecture should have followed Professor Levy's lecture, is a very specific complication of monochorionic twins, which is the twin-to-twin transfusion syndrome, which is based on the presence of certain vascular anastomosis on that single shared placenta. Just to remind you, the diagnosis before birth is easy and quite decisive. You make this diagnosis purely based on ultrasound. You already know that it is a monochorionic twin. We actually treat up to 28 weeks, and it is the combination of oligo and polyhydramnios. Polyhydramnios, which in Europe is defined with these cutoffs, 8 or 10 centimeters, and even earlier in gestation we are a bit more liberal, coinciding with oligohydramnios, as you can see here on these images. Again, early in pregnancy, as the amniotic fluid is also produced by other organs than the kidneys, we are more liberal. Now, there may be other conditions present with them, but I'm only speaking about twin-to-twin transfusion syndrome, or TOPS. It is a condition that is progressive. The disappearance of the bladder makes it a stage 2, and after that you can have combinations with cardiac decompensation, changes in the recipient twin, as well as changes in the donor twin. It can lead to hydrops, and eventually it may lead to fetal death. But somewhere in that course, you may be offering a causative therapy, which is no more than the fetoscopic inspection of the recipient's placenta and the identification of anastomosis, which can be easily coagulated with laser. It's a procedure under local anesthesia, dependent on good visualization, and the endoscopes we use are about 1.2 to 2 centimeters. So for the mother, it is a trauma of no more than 3.3 millimeters. The surgical aim of the operation is to bichorionize the placenta, to make 2 functional placentas. And when you do so, there is level 1 evidence that this improves not only the survival compared to amniodrainage, but also it delays delivery, still premature, but up to a level of 34 weeks, with as a consequence that on the short and medium term, the neurological morbidity in this condition is reduced. We also know that this is cost effective, because when you are thinking about this operation, we need to know whether it reduces not only the morbidity, but that comes at a reasonable cost. And in a relatively old study, based on US numbers, they could demonstrate that although this procedure costs more than amniodrainage, that on the long term, there is a benefit which is significant, more than 40% difference in quality of life adjusted years. And even if you calculate the cost of cerebral palsy to be either not very much, because babies may die, or quite a lot if they need to be treated on the longer term, that remains a positive balance. The second condition for which there is level 1 evidence is diaphragmatic hernia. Most of them are left-sided. I'm not talking about cases that have conditions that are associated to it, but when the condition is isolated, it leads to underdevelopment of the lungs, pulmonary hypoplasia, at birth, becoming obvious as ventilatory insufficiency and pulmonary hypertension. When babies survive the neonatal period, they may have longer-term morbidities, but most of them disappear after the age of 2 for feeding problems and after the age of 5 for pulmonary problems. Globally, the mortality is still 30%. The prenatal diagnosis in screening programs is made in 2 out of 3 cases, which gives you the opportunity to define that particular fetus that may not survive because it has very small lungs, and I will show you data that it can be treated before birth. The identification of fetal surgery candidates is done by ultrasound, which is widely available, very standardized, that you can look up in this publication how you measure the lung to head ratio and how you correct for gestation. And you can, with ultrasound, define liver herniation, which gives you this algorithm that has now been validated 3 times in independent cohorts, going from left to right, a very small lung size, 15% or less of the normal, to around 50% of the normal. And in the trial that I will present to you, we have looked at the middle part of the population. Around 45% of fetuses with left-sided CDH have what we call moderate hypoplasia and survival chances of 50%. But we also looked, of course, at the ones that are nearly certain to die, the ones with severe hypoplasia. And the treatment is different dependent on the severity of the hypoplasia. In severe hypoplasia, we do an operation at 27 to 29 weeks, where in the randomized trial we did a late tracheal occlusion in the fetuses that had moderate hypoplasia. The experimental basis for tracheal occlusion is that, number 1, anatomical repair being possible does not solve the problem for fetuses with liver herniation, because it causes acute kinking of the umbilical vein. So therefore, we do a occlusion of the trachea, which has been shown in congenital malformations to make the lung grow, and we can do it minimally invasive. Clinically, it's a procedure that is no different from laser treatment for transfusion syndrome. It happens under local anesthesia with fetal immobilization and fetal anesthesia, and an endoscope is basically put into the fetus mouth and into the trachea to deliver a vascular occlusion device that is used off-label, is left there until it will be removed at 34 weeks in pregnancy. You can now see at the bottom right how the endoscope is in the trachea and how a balloon will be left between the carina and the vocal cords. This is a detachable balloon. It is to be removed surgically at 34 weeks, as you will see in a second. So, of course, these babies are born with obstructed airways if you don't remove the balloon. We remove it at 34 weeks to induce lung maturation, either by simple ultrasound-guided puncture, fetoscopy, or removal on placental circulation in a standard cesarean section. I will not give you any preliminary results of earlier studies, but there is the randomized trial called the total trial, which has shown unequivocally that the survival rate after tracheal occlusion is more than 2.5 times higher with fetal surgery. However, in the more moderate cases, there was an increase by 30%. However, that did not reach significance. This procedure leads to prematurity. On average, babies are born at 34.5 to 36 weeks, which of course can offset the effects of fetal therapy. How can you understand that a procedure is so potent if you do it in severe hypoplasia earlier in pregnancy and that you don't have a significant effect if you do it in less severe cases? We have tried to understand that, and what you can see on the left is a graph of the relationship between the lung size, lung to head ratio, and survival. And what you can see in black is the natural history. In blue, you can see the fetuses that got late tracheal occlusion, and in red, the fetuses that had an early and longer tracheal occlusion. And what we could show is that when you insert the balloon late in pregnancy, there is a treatment effect, but the treatment effect is boosted by putting in the balloon earlier and leaving the occlusion for a longer time. Together with that, of course, if you go earlier, you will have more prematurity. Meanwhile, in a systematic review, this has been confirmed also in other people's hands. It decreases pulmonary hypertension and ECMO, and it indeed induces prematurity, but it is a late prematurity and not an extreme prematurity. Now, it is a safe procedure. Just like laser, we know that fetal doesn't cause often severe complications, 1% chorioamnionitis and abruptio. We also know it doesn't have long-term effects on the mother. Their obstetric and gynecological outcome is normal, but the psychological impact of having a fetus with CDH that may or may not survive is... Could somebody just not touch the slides? Thank you. So you can understand that it has a huge psychological impact. In terms of fetal safety, there is a 1% risk of intrauterine fetal death tied to the condition, and of course there can be neonatal death if you are not able to remove the balloon, which can be dependent on the patient as well as yourself. The occurrence of tracheomalacia is very low. Now, how can this procedure come to your country? Well, one of these devices that we use is this vascular occlusion balloon. We are currently doing a phase 1 trial with a balloon that will change the life of the fetal surgeon. It is a balloon with a magnetic valve that you can activate from the outside by using a magnet, letting the patient walk around an MRI machine, which actually deflates the balloon. And imagine for a setting like this country that is huge, if you have patients coming for a balloon occlusion, they could be managed locally to deflate the balloon. Now, to finish, we will speak about a non-lethal condition, that is spina bifida. The assessment of severity is done by determining the lesion level, and based on the lesion level, we will be able to predict pelvic floor dysfunction, which is tied to low lesions. In the case of a lumbar lesion, the level that is important for walking or not walking is above L4 or under. You can see that the chances for independent walking go up as the lesion is lower, and for thoracic lesions you can have associated malformations of the chest, or of the spine in the chest. Also, the severity of hydrocephaly can play a role in the prediction of the outcome. 70% of fetuses have a normal IQ. Their hydrocephaly is such that 80% of fetuses will require a shunt after birth. And when you repair this condition anatomically, you actually decrease significantly the level, the number of fetuses that will require a shunt. The number of fetuses that will be able to walk is twice as high after surgery before birth, and these differences persist later in life. There are now outcomes on this randomized trial up to 10 years, and you can see that these differences persist until later in life, and even bladder function has been shown to improve. We are offering this procedure now also 10 years, and you can see, don't read this slide, we can mimic these results in a other setting. In other words, you can learn to do this procedure with similar outcomes. To confuse you a little bit, but this is a meeting about the future, this procedure is undergoing tremendous change from open surgery via hysterotomy under general anesthesia to percutaneous fetoscopy and things in the middle like mini hysterotomy or fetoscopy but with exteriorized uterus. Now, when you look at reducing the incision by making a cut of 6 to 7 centimeters in the uterus and bring it under 3.5, we have been able to show that the reduction in the incision not only decreases prematurity, but also that you have equally good results on the longer term in terms of shunts and walking. And of course, what it dramatically changes is that it reduces the risk for uterine dehiscence and rupture. And as you can see here, also in our hands, this has reduced prematurity very significantly. Now, the future, of course, is that we do this without real incisions in the uterus. We can do this by fetoscopy. As you can see, the procedure, the anatomical repair, is completely mimicked but modified, because we cannot really do the same surgery, to cover the spinal defect and actually having a better outcome. This is research. It is not known whether these procedures have the same results. So if your patient chooses to have this surgery, we will have to follow them up to see if they have equal results. So to finish, I would like to say, you have the tools to identify fetal surgical conditions. There is level 1 evidence that laser treatment improves the outcome of TTTS, fetal for congenital diaphragmatic hernia, and spina bifida repair improves the morbidity of spina bifida. All of this persists later in life, has been shown to be cost effective, so it is time to implement them widely around the world. And I think you know as well as such that also in Egypt this is becoming available. Yesterday our university was glad to sign Memorandum of Understanding, and 2 of your colleagues have been trained in Belgium, so very soon in time you will have your first laser shot at Ain Shams University. Thank you very much on our behalf.
Thank you very much, Professor Jan. Now the floor is open for any questions, if anybody has a question. Okay. Now we will listen to Professor Elizabeth Lewis. She is a consultant of fetal-maternal medicine at Leuven, Belgium, and she will be talking to us about monochorionic twins.
Thank you very much. Can I see the, or do I have to look? Can I see my slide? Okay. Okay, fine. Yes, so thank you very much. For 20 years I've been looking after monochorionic twins, and it's a pleasure to give you an update about how to follow these high-risk pregnancies. Okay, so first I will highlight why these are high-risk pregnancies and then also the typical complications. The transfusion complications, which are twin anemia polycythemia sequence and TTTS, and then the complications that are not unique to monochorionic twins but require a different management, which are anomalies and poor growth. I will address the follow-up in the first, second, and third trimester. So the problem with monochorionic twins is not so much that they share one placenta, but that there are vascular communications, like Jan said, the Siamese placenta. And we know that in 15% of these pregnancies, an imbalance in intertwin transfusion occurs, either TTTS or TAPS. And that makes, this shared circulation makes that the risk of loss prior to viability is twice as high in monochorionic twins, and also they're at increased risk of perinatal demise and very early birth. So that's why it's important that in the first trimester, every twin should have the chorionicity determined, and it can easily be done by looking at the intertwin septum. So in the monochorionic twins, you only have two thin amniotic membranes separating the twins, whereas in dichorionic twins, you have the two thin amniotic layers, but then in the middle, there's the thick chorionic layer in the dichorionic twin pairs. And you can confirm the chorionicity after birth also by looking at the intertwin septum, where you have the two thin amniotic layers in monochorionic diamniotic twins, and you have a thick chorionic layer in between the two thin amniotic layers in dichorionic twin pairs. Now the first most important transfusion imbalance is obviously the twin-twin transfusion syndrome, which is basically a severe difference in amniotic fluid volume. And importantly, we have very strict criteria to define TTTS. So the donor baby should have an oligohydramnion with deepest vertical pocket less than 2 centimeters, and the recipient twin should have a polyhydramnion, and then we use gestational age-dependent criteria, so it should be more than 6 before 16 weeks, more than 8 between 16 and 20 weeks, and more than 10 after 20 weeks. And usually there's a small or empty bladder in the donor baby and a massively distended bladder in the recipient twin. So these criteria are essential. We don't offer fetoscopic laser surgery unless the criteria of amniotic fluid discordance are fulfilled. And this is a clip of a twin pair with twin-twin transfusion syndrome. And so we know that most cases occur prior to viability, and that's also the reason why if you don't treat them, they invariably lead to the loss of the entire pregnancy. And even with the best treatment, which is fetoscopic laser surgery, TTTS remains the most important reason why we lose monochorionic twins or why they sustain long-term handicap. So 1 in 10 monochorionic twins will develop twin-twin transfusion syndrome. And obviously these twins are eligible for fetoscopic laser surgery, as Professor De Pest highlighted. This is the, with level 1 evidence, proved best treatment for twin-twin transfusion syndrome. And we don't only coagulate the vessels, we also draw a line from one side of the placenta to the other side, just to prevent that there are missed anastomosis. And we know that nowadays we can tell parents that there is at least 90% that at least one baby will survive, in 65% both babies, and in 10% we still lose both babies, and that's mostly due to miscarriage or extreme preterm birth. Unfortunately, there are still born on average very preterm, and 1 in 10 children sustain long-term neurodevelopmental impairment. So that's important information to counsel prospective parents. The other transfusion imbalance that can occur in monochorionic twins is twin anemia polycythemia sequence. That's not the difference in amniotic fluid, but in hemoglobin values between the twins, and these are picked up prenatally by looking at the middle cerebral artery peak systolic velocities. also a discordance in this middle cerebral artery peak systolic velocity. But there are additional clues, so the very dark liver in the recipient baby and the very echogenic liver in the anemic donor baby, and also the typical placental dichotomy where you have a thin dark part of the recipient baby and a thickened white part of the anemic donor baby. And TAPS is less common than TTTS, it's 5% of monochorionic twins, and usually, although it can occur anytime in pregnancy, usually it occurs in late pregnancy. Now, in contrast to TTTS, the best management for TAPS is less well established, and usually when we diagnose discordances in the middle cerebral artery peak systolic velocity, we will initially be expectant. As you can see here on this Marie curve, the very early TAPS cases usually disappear spontaneously. But obviously, if you have a severe TAPS in mid-pregnancy, then you can perform fetoscopic laser surgery. And TAPS typically have these minuscule connections, which you then also ablate using fetoscopic laser, and that will also cure the TAPS sequence. Obviously, if there's a severe anomaly in one of the babies, you can also perform selective reduction by umbilical cord coagulation. You can, when you're late in pregnancy, you can postpone delivery by giving intrauterine transfusion, which is more a palliative treatment. And once you're above 30 weeks, you can opt for an elective preterm birth. The other problem with monochorionic twins is discordant anomalies. It's not unique to monochorionic twins, but they are more likely to have an anomaly, and usually it affects only one baby, although they are monozygotic. Usually only one baby is affected. And the reason why there are more anomalies can be due to the cleavage of the embryo, but also complications of the shared circulation, like spontaneous limb amputation in the polycythemic recipient in TAPS. Chromosomal anomalies are less common in monochorionic twins, probably because they're more likely to lead to miscarriage, and usually both are affected, but it's important to realize that discordances can occur, and that's due to mitotic errors in the early embryo. And then in the first trimester scan, you will see one normal baby, and then in Turner syndrome, for instance, if one baby has Turner syndrome, a cystic hygroma in one baby. If there's a severe discordant anomaly, then parents can opt for a selective reduction, and in monochorionic twins you cannot use intracardiac potassium chloride. You need to isolate the circulation of the affected twin to prevent acute exsanguination of the surviving baby, and you can use intrafetal coagulation, which is the preferred treatment for twin reverse arterial perfusion sequence. You can use ultrasound-guided bipolar cord coagulation, which is the most commonly used technique, but you could also use fetoscopic laser cord coagulation in early cases, and that's the similar technique as you perform your laser coagulation in TTTS, but instead of the anastomosis, you target the umbilical cord. And then finally, selective fetal growth restriction, when there's a significant difference in size between the babies. That's also something that occurs in monochorionic twins, and then obviously we know that if you look at the umbilical cord perfusion of the smaller baby, that predicts your prognosis, and if the flow is normal, these have excellent outcomes, but if the umbilical artery Doppler flow is abnormal, these have a complicated outcome. And these abnormal umbilical artery Doppler twin pairs, you can either manage expectantly, and that's what we usually do, and then you have a 60% survival in type 2, 85% in type 3. Also, selective reduction would be an option if there's imminent demise of the smaller baby, but the overall survival is only 40% because obviously you lose the smaller twin. And the role of fetoscopic laser surgery in selective fetal growth restriction is not something that we would recommend as first-line treatment because it does not cure the condition, and also we know that the overall survival rates are disappointing. So most of the time, selective fetal growth restriction can be managed expectantly. Now for the follow-up in the first trimester, that's where you determine the chorionicity, you date the spontaneous twin pregnancies based on the crown rump length, you label the twins, And you also perform a detailed anomaly screening. And therefore we follow the ISOWOC guidelines. And we know that most of the defects, actually more than 50% of all congenital defects, especially heart defects also, are already detectable in the first trimester. For aneuploidy screening, you can use the combined screening where you take the average of the nuchals to calculate the combined risk of the pregnancy of both babies having Down syndrome. But we also know that the NIP tests, because they are monozygotic, are very accurate to determine the risk of chromosomal abnormality. In the second trimester, obviously at 20 weeks, you screen for anomalies where you follow also the ISOWOC guidelines, and preferentially it's an experienced operator, and also you have sufficient time to inspect both babies. And then you follow them up for their growth to detect selective fetal growth restriction. You look for twin-twin transfusion syndrome, and you look for the free-floating membrane. And so as long as the membrane is free-floating between the babies, there's no twin-twin transfusion syndrome. And as long as both have normal bladder filling, you know this is not a TTTS. And also, you should measure every time you see the monochorionic twin pair, the middle cerebral artery peak systolic velocities to screen for twin anemia polycythemia sequence. And this is a summary of the follow-up of monochorionic twins. So basically, this is the follow-up as for dichorionic twins, but then in monochorionic twins, there are additional evaluations. So every 2 weeks, from 16 weeks onwards, you should scan your monochorionic twins to screen for TTTS and TAPS. And then regarding the delivery, all monochorionic twins should be delivered by 37 weeks, because we know that the risk of intrauterine demise increases after 37 weeks. And they can be delivered vaginally. Monochorionicity is not a reason to perform a cesarean section. That has also been clearly demonstrated. So thank you very much. That's what I wanted to tell about the follow-up of monochorionic twins. And thank you also to the team in Leuven.
Thank you very much, Professor Lisbeth. If we have any questions, the floor is open for questions.
Yes, please.
In severe TAPS, we do laser photocoagulation for the placenta. What do you mean by severe TAPS? According to the mean systolic velocity of peak systolic velocity of the middle cerebral artery, or how can we grade the TAPS?
So what's the question? How can we do what in TAPS?
Laser photocoagulation for the placenta in severe TAPS. How do you define the severe TAPS?
The severe TAPS is a very good question. So we would only offer fetoscopic laser surgery in TAPS. I must say this is not proved by any randomized controlled trials, but if you have a severe TAPS, which means there are abnormal umbilical artery Doppler or abnormal ductus venosus in the smaller baby, or additional signs of anemia like pericardial effusion, ascites, so beginning hydrops in the donor baby with increasing middle cerebral artery peak systolic velocities. At around 20 weeks, you know that with transfusion, you are not going to get to a good stage in pregnancy, so that are the cases that are eligible for fetoscopic laser surgery. Thank you for your question.
Thank you, Dr. Elizabeth, for a very nice presentation. I want to know about the rare occasion when you are having a twin-to-twin transfusion and you have discovered that one of the twins has died just today. Just in the same day, and you have diagnosed that it's just
Yes.
Does this justify immediate termination in the same day, or would you think that?
No, once a heart has stopped in one of a monochorionic twin pair, there's no use of doing any laser or bipolar cord coagulation. So if the heart has stopped completely, you come too late to save the other one. So the only thing you can do is measure the middle cerebral artery peak systolic velocity and offer a blood transfusion if the surviving twin is anemic. We have done emergency cord coagulations. I once had a patient in the clinic where there was bradycardia, So as long as there is some heart activity, yes, you can offer an urgent fetoscopic laser intervention or bipolar cord coagulation, but once a heart has stopped, you are too late. Thank you.
Okay, thank you. Allow me please to introduce Professor Emma Ferryman. She will give us a talk, medical legal issue in obstetrics. Professor Emma is a consultant in obstetrics and gynecology and fetal medicine, Sheffield, UK. She is a subspecialist in fetal and maternal medicine. She is the medical legal practice advisor to the GMC, editor and author of medical legal publications. Thank you.
Thank you very much for your kind introduction and for your very kind invitation to this amazing conference. So I'm going to briefly talk to you about something that's very topical, which are the medico-legal implications of being an obstetrician, which is something I think that we face with whichever country that you work in the world. So everybody, every parent wants a perfect baby. That's the expectation. And a perfect outcome is obviously the mission that we want as obstetricians. This problem is not a new one. From as early as 1994, there was a study of obstetricians in the northwest region in the UK that showed that over 75% of obstetricians had been involved in some form of litigation. In 2002, in an Australian study of over 800 practitioners, only 44% decided to continue as obstetricians, and among the reasons stated was fear of litigation and the rising costs of indemnity. In a study in the Washington Post in 2015, 76% of obs and gynae doctors in the US had also been sued at least once. This is some data from a malpractice report in 2015, and you can see that obstetrics and gynecology has the highest risk of litigation when compared to other specialties, including orthopedics. So what's the scope of this problem? Well, we all know that an adverse outcome in obstetrics can be absolutely catastrophic and will be life-changing for families. Obstetric litigation, however, primarily occurs in developed countries, and that's usually through lack of knowledge and development. Clinical claims in obstetrics continue to be the most expensive worldwide. In the UK, the claims identified to the Clinical Negligence Scheme for trusts will make up only 11% of claims, but they account for about 59% of the total cost. And in 2021, that was £4.2 billion. Obviously, the highest costs around birth injury. And so spending money on medical negligent claims is escalating. And in fact, the same pot is used for supporting those claims as it does to fund our NHS services. Our small numbers of high-value claims in obstetrics are draining the NHS. This is a graph from 2021 and 22 showing that there were over 1,000 obstetric claims. In total, they only accounted for 12% of claims, but there was 62% of the overall value. That was a total cost of £13.3 billion. So what is medical negligence? Well, this occurs when a health professional performs their duty in a health institution in such a manner that avoidable harm befalls the patient. So a medical doctor who omits to do what a reasonable doctor would do or performs an act which a prudent and reasonably practitioner would refrain from doing, and as a result of that there is damage to the patient. So how is a doctor judged to be negligent? Well, we have to demonstrate that there's an existence of a duty of care to the patient, that there has been a breach of duty by the doctor, and that that breach has resulted in damage or injury to the patient. The types of medical negligence are usually into three categories. A diagnosis-related negligence, so that might be failing to diagnose preeclampsia when you've got high blood pressure and proteinuria. It might be uterine rupture by allowing a woman who's had 3 previous caesarean sections to labour. We then move to advice about counselling or counselling-related negligence, and that's when you fail to provide all the risks, so for example of assisted vaginal delivery versus the alternative treatment of caesarean section at full dilatation. And then there's treatment-related negligence, where you might talk to someone about a treatment and they don't have the appropriate consent, and obviously there are the complications of that potential treatment. So the key principles of litigation is that as soon as a case is identified, a lawyer will instruct an expert in either obstetrics or midwifery, and they will look at the case. Remember that clinical practice, though, has changed over time. So a good example of this would be change before and after the term breach trial in 2000, when the conclusions from that trial suggested that vaginal birth was more dangerous and elective caesarean section should be offered. In the UK, medical negligence is governed by the statute of limitations, and that will usually be within 3 years of the alleged injury. However, in obstetrics, there are some notable exceptions. So, for example, in brain injury, the 3-year limit does not begin until the disability ends, and as we all know, that disability will be ongoing. Also, where the injury affects a child, the 3-year limit does not apply until the child reaches 18, so the negligence must be filed by the age of 21, and this would be appropriate for some cases of shoulder dystocia. So these are our key areas, which I'm sure as obstetricians none of you are surprised about. Obviously the highest risk cases are going to be those from neonatal encephalopathy and brain injury. This is some data from the NHS Litigation Authority looking at 10 years of maternity claims between 2000 and 2010. And the 3 commonest causes of claims were the management of labour, caesarean section and cerebral palsy. And of course, the most expensive were labour management and cerebral palsy, with CTG interpretation accounting for over 70% of claims. With this end, the NHS Resolution Authority decided to look at 10 years of claims for cerebral palsy. And between 2012 and 2016, there were 50 claims with a potential financial liability of over £390 million. The themes arising were poor quality investigations, with the family involvement in only 40%. In only 32% was there appropriate review by an obstetrician, a midwife and a neonatologist, and in only 4% was there an external review. Themes again were CTG interpretation, breech birth and vaginal delivery, inadequate staffing and lack of informed consent. Consent in the UK took a massive turn in March 2015 when the landmark case of Montgomery versus the Lanarkshire Health Board occurred. Nadine Montgomery was a petite diabetic lady over-intelligent. She actually worked in a university and she was very concerned during her pregnancy. She was diabetic and she had a baby that was macrosomic. She didn't specifically request a caesarean section, but she was really worried about her ability to deliver the baby. The pregnancy was complicated by an 11-minute shoulder dystocia, and her son has developed severe cerebral palsy. The obstetrician in this case claimed that the risk of shoulder dystocia was insignificant, the risk was small, and therefore there was no obligation to discuss it. Mrs. Montgomery stated that if she had been aware of the risks of shoulder dystocia and offered a caesarean section, that she would have opted for that, and this would have avoided her son's cerebral palsy. Currently, the case has accumulated £9 million in damages and is ongoing. So consent after Montgomery, it is the patient and not the doctor who determines how much information is required for consent. Previously, this information was down to the doctor. The doctor must take reasonable care to ensure the patient is aware of all material risks. And the materiality test is where a reasonable person in that particular circumstance, how they would be likely to attach the significance of an individual risk. So the material risk has to be explained by looking at the nature of the risk, the effect it will have on the patient, the importance of the potential benefits of treatment to the patient, any alternative treatments, including no treatment, and the risks involved in those treatments. Without these, you cannot get informed consent. So what are the principles for safer care? Well, we need an investment in staffing and infrastructure, a commitment to learning, and we need to learn from our successes. We need to enable and support system-wide safety improvements. The early notification scheme for trusts is another invention from the NHS resolution looking at to reduce maternal and neonatal deaths. And it was specifically introduced to look at brain injury and to reduce the legal costs in terms of compensation. The issues here are that any learning should be shared rapidly with the individual trust, and there should be a willingness to say sorry and be fair. We will also improve the compensation processes for families by reducing the risks of claims increasing in value due to inflation and the unmet needs or psychological damage of parents. Criteria for reporting are babies delivered over 37 weeks in labour with a potentially severe brain injury which is diagnosed in the first 7 days of life. The criteria are grade 3 HIE, they have to undergo active therapeutic cooling, and there must be reduced central tone with comatose and seizures of any kind to be eligible. Also in 2014, the duty of candour came into being. Prior to 2014, there was no obligation for care providers to share information with injured families. This case in 1990 of Robbie Powell was a landmark case, and this was a baby who died following an Addisonian crisis. In May of 2000, the European Court of Human Rights said that as the law stands, doctors did not have a duty to give parents of a child who died as a result of their negligence a truthful account of the circumstances of the death, nor even refrain from deliberately falsifying records. Following the Francis inquiry in 2013 into mid-staffs, a statutory duty of candour was introduced, and this was made law in 2014 as part of the Health and Social Care Act. This offers honest answers to patients and their families when a problem occurs. So, the question I think you all want me to answer is it possible to avoid litigation? No. All I can do is to give you some advice for clinical practice. You need to be familiar with the best practice documents of your country, so for us that's RCOG and NICE. And where you deviate from best practice, you need to document your rationale for doing so and obtain informed consent. Refer to another specialist where a procedure falls outside your area of expertise and discuss complex cases at MDT. Plan any treatment with the patient, advise on alternative treatments or no treatment, and there should be a patient-specific approach. Document rationale for any departure from best practice and investigate or refer patients with ongoing unexplained symptoms. Act quickly when a patient fails to recover appropriately. The importance of accurate, dated and timed medical records cannot be stressed. Examinations should be documented, especially when obstetricians rely on midwifery examinations. Document delays, delays to theatre, delays decision to delivery times. Document discussions with seniors. The use of performers for obstetric emergencies will also be helpful, particularly for shoulder dystocia and PPH, and write statements in advance when you've been involved in adverse outcomes. Report all adverse outcomes, ensuring that there is transparency within your unit, and debrief following difficult deliveries or adverse outcomes for both staff and patients. Most importantly, adopt the duty of candour, be open and honest when errors occur. So in summary, Obstetric litigation is a growing problem, and all obstetricians in this room will be involved in litigation at some point. The emphasis has to be on good documentation, be up to date with current guidance, ensure MDT working, and debrief family and staff after adverse outcomes. But most importantly, be open and honest with your patients when things go wrong. Many thanks for your attention.
Thank you, Dr. Emma. Very nice presentation. Of course, we need to elaborate the difference between the litigation system in Egypt and the litigation system in England. So, in Egypt, the litigation system that if a patient files a complaint, the doctor will be tried according to the civil law, not according to a medical law. So, he will be tried in front of a judge, not in front of a doctor. But the report of the patient will be sent to a committee of 3 doctors in the same specialty.
Yes.
So can you please elaborate what is the difference in the NHS system if you have somebody who has a complaint? Does it go, which route does it go?
So in the UK, the patients, obviously the majority of our patients are under the NHS, so they're not in private practice. So they would then seek the advice of a solicitor. The solicitor would get the medical records and they would then employ the relevant experts, so whether that's an obstetrician or a midwife or a neonatologist. They would go through the medical notes, they would look at them, and they would decide whether there were any areas of potential breach, and most importantly, whether that breach had actually led to an issue with the patient. Once that process is formalised, the solicitor would then send a letter of claim to the hospital, and the hospital has 28 days to respond to that letter of claim, and the hospital will be represented again by their own lawyers, who would then instruct experts working on behalf of the hospital. At that point, there would be a letter of response, and it would be up to the claimant to respond to the letter of response. So this may go back and forth for a number of months, a number of years. What we know is that if there can be no agreement between the 2 parties, no compromise, then the case will go to trial in front of a judge. There won't... A normal judge, yes. So that is a normal court of law. The only experts are employed on behalf of the claimant and on behalf of the defendant. What you've got to remember in the UK is less than 1% of all these cases go to trial. Less than 1%. Thank you for your question. Hello there.
Well, Agur, Scotland. I really enjoyed your talk. Very interesting to see how we all cannot avoid litigation at any point in our lives. Clearly, Montgomery has changed the consent landscape in the UK with regards to risks communicated. There was an attempt this summer in Supreme Court, in UK Supreme Court, to do the same for reasonable options. But this attempt has failed. So that was McCulloch versus Forth Valley NHS Health Board. And I find it quite strange to think that one legal test applied for risks, which is Montgomery, in terms of who determines what risks to be communicated. And the answer was a reasonable patient, a reasonable person, or a reasonable doctor. But we talk about reasonable alternatives, only the doctor determines these. So the legal test is quite different. And I find that quite unusual, and I wonder if you have any views on that.
Yes, I mean, it's very difficult, isn't it? Because we all know as obstetricians that we will give patients different options, and individual obstetricians will give them slightly different options. And I think the issue in all of these cases, when they're actually put before a judge, is that the claimant actually has to convince the judge that they would, having given an alternative option, they would have gone for that option. So the issue particularly comes for things like being offered elective caesarean section, and you know, routinely we wouldn't in the UK offer a primigravida with no other risk factors, a caesarean section, that if the claimant can convince the judge that had she been offered that, she would have gone for it, then obviously the case potentially could succeed. And it will very, very much depend on the individual judge and the way that the evidence is put to them. Thank you.
Thank you very much for the nice talk.
You're very welcome.
You touched on my question briefly, but can you just give us more advice about how medical legal binding are guidelines, like Green Top guidelines or guidelines from American Society or European? In other words, I mean, you said if you're deviating from this, you have to document your rationale, but how defensive is this? If you did not follow the Green Top guidelines, is this a black and white deviation from good practice, or there is still a leeway for individual experience or different circumstances?
Yes, I think we all know that when we look at our, so the guidelines in the UK will be on two levels, won't they? There'll be the trust guideline, the one that you work to locally, and then the national guidelines. And I think the most important thing that is if a trust guideline would be the one that the obstetrician will be working to locally. But in order for that to be validated, they have to have a good reason if that trust guideline departs from national guidance. And again, that would be up to the judge to decide that. So it's quite harsh, really, because an obstetrician can be working within their own guidance, but if that's slightly out with, say, NICE or RCOG guidance, then potentially that is an area of criticism. So, as I said, if you are going to depart from guidance, you need to document clearly why you've departed from that, and that you have had an MDT discussion with other colleagues that will support your reasons for doing so.
Ask a question. Okay. Hatem will say, okay. A very quick question. Do you feel that litigation affect the trainees and the consultant in one side? And the second is, are we moving towards defensive practice? Because, for example, in Egypt, maybe cesarean section for patients is an option to avoid any litigation in labor. And the same in the United States. So do you feel, are we moving towards that? And secondly, how it affects the trainees? Because we have trainees went out of training after litigation. Thank you.
Yeah, I mean, thank you for your question. I think that's very important. And I think one of the
Okay, so
Sorry. So I think one of the areas where we see that is particularly with instrumental delivery, and certainly we've been teaching over the last couple of days, and the issue of doing a full dilatation section against doing a very complicated vaginal delivery. So I would agree with you that that is de-skilling our trainees, because people are frightened of having a complicated delivery in the second stage. Sorry for running over.
Thank you, Emma. Can we move now to Dr. Tess Bonnet? Dr. Tess is a professional in fetal-maternal medicine, and actually she has been involved in setting up the first joint multiple sclerosis pregnancy clinic in UK. She is providing care to pregnant women with pulmonary hypertension and vascular EDS. She is going to talk about the role of obstetric physicians and what's new in maternal medicine.
Good morning. Thank you so much for the introduction and for the invitation to speak today. So I bring you greetings from Sheffield in the UK. Sheffield is a very hilly city in the north of England. My brief today is to provide an update on what's new in maternal medicine. This is an overview of what I'll be covering today. I'm going to start off by discussing maternal medicine networks and the role of the obstetric physician. I want to highlight some important messages regarding cardiovascular disease and epilepsy that have come out of recent confidential inquiries in maternal deaths. And then I have a few headlines relating to maternal medicine. We're going to discuss how recent studies have changed management of intrahepatic cholestasis of pregnancy. We're going to discuss Kaftrio, which is the new wonder drug, which is revolutionising reproductive health care in women who have cystic fibrosis. Brief discussion about prenatal diagnosis in haemophilia. And finally, I'm going to look at how management of chronic hypertension in pregnancy is changing. So the most significant development that I've seen in maternal medicine over the last 10 years is not a new drug or groundbreaking research. It's been a reorganisation of the way that we deliver care for women who have complex medical conditions in pregnancy. So over the last 5 years, England has been divided into 17 regions or maternal medicine networks. So in Sheffield, we're part of the Yorkshire and Humber Maternal Medicine Network. You can see on the map the area that we cover. So the aim of maternal medicine networks is to provide equity of care across geographical areas. So we all know that a woman who lives a significant distance, 70 or 100 miles away from the tertiary referral centre, may have greater difficulty in accessing specialist care than the woman who lives very close to the tertiary centre, maybe in the same city. And the maternal medicine networks aim to reduce this inequality in access to care. So how is this organised? Each region has 1 or 2 maternal medicine centres, that's the tertiary referral centre, and the surrounding hospitals are referred to as spoke hospitals. So it's organised like a bicycle wheel. The maternal medicine centre will have specialist obstetricians, anaesthetists, physicians and midwives who have specific training in caring for women with medical conditions in pregnancy. So what conditions are we referring to? So pre-existing medical problems like congenital heart disease, asthma, epilepsy, rheumatological disease, inflammatory bowel disease are just a few examples. So the maternal medicine network is also there to provide care for women who develop new medical problems in pregnancy or the postnatal period. For example, venous thromboembolism or peripartum cardiomyopathy. The network also provides preconceptual counselling for women with existing medical problems who are planning a pregnancy. So when a woman is referred to the maternal medicine centre, there's 3 options available. It may be appropriate for a woman to be cared for solely in her local unit, the spoke unit. So these patients are category A patients. And examples of category A conditions are well-controlled epilepsy or stable inflammatory bowel disease. Category B patients are more complex and require specialist input. So care is shared between the local hospital and the maternal medicine centre. These patients might have chronic kidney disease or a mild bleeding disorder, for example. The aim is to keep care as local as possible while still providing access to specialists in the maternal medicine centre. Category C patients are the highest risk patients. They might have complex congenital heart disease or portal hypertension or be a carrier of severe haemophilia with an affected fetus. And for these women, the majority of care will be in the maternal medicine centre and women will usually deliver there too. Regular MDT meetings are held to plan care for women, so to plan care in the antenatal period, planning for delivery, and a postnatal care plan, including handing care back to the parent-physician team after pregnancy. So these are the members of the maternal medicine MDT. You've got an obstetrician with a special interest in maternal medicine, anaesthetist, obstetric physician, I'll come more onto that in a moment, a physician for the different specialties, dietitian, midwife, with a special interest in maternal medicine. We work closely with specialist nurses, like epilepsy specialist nurses and diabetes specialist nurses. We also need to involve the physiotherapist. The pharmacist plays a crucial part as part of the MDT because a large part of the role of the maternal medicine network is to provide advice about the safety of different medications in pregnancy and breastfeeding. We may also include a geneticist. So going hand in hand with the rollout of maternal medicine networks has been the development of the role of the obstetric physician. So this is a very new medical specialty. 10 years ago, there was only a handful of obstetric physicians in the UK, mainly based in London or Oxford, Cambridge. But there's been a recent programme of training to train an obstetric physician for each of the regions. How do you become an obstetric physician? Well, these are physicians who've nearly completed their training or have completed training and who can undertake additional training in obstetric medicine. And this training is run by the Royal College of Physicians. So these obstetric physicians will usually have their own medical specialty, for example, cardiology or renal or diabetes, and then they will have additional training. And they will see women for preconceptual counselling and be involved in care planning in the antenatal and postnatal period. I feel very aware that this is a UK-based initiative, but I think there are principles that are very transferable to different hospital settings in Egypt. So the future of maternal medicine is collaborative care. You may not have an obstetric physician, but the key is to find pregnancy-interested allies amongst your physician colleagues. So my experience is that in any given specialty, there will usually be one or two physicians who are interested in how their specialty overlaps with pregnancy. And these are the colleagues to collaborate with. Obstetricians and physicians think differently about medical problems, and we provide the best care when we share decision making and we work together to develop plans for the antenatal period, delivery and the postnatal period. So the transition back to the parent physician team after pregnancy as well is so important. Are there follow-up plans in place? Does the woman need to restart medications that were stopped in pregnancy, for example? I also wanted to highlight this very useful document that was published by the Royal College of Physicians in 2019, the Acute Care Toolkit. It's available on the Royal College of Physicians website. My colleague who's following me after this, Dr. Surabi Nanda, was involved in writing it, and it's a very practical guide to managing acute medical problems in pregnancy. It focuses on the investigation and management of chest pain, breathlessness, palpitations and headaches, and deterioration in mental health. And it's a really useful resource for obstetricians, physicians, and the emergency department. So I would really commend this document to you. So moving on, the next few slides are very brief headlines about recent developments in maternal medicine. So I'm going to start off with two important messages from recent confidential inquiries into maternal deaths published in 2021 and 2022 respectively. The first is regarding red flag symptoms in cardiovascular disease. So we know that cardiac disease is the second most common cause of death in pregnancy. And the message is that a wheeze that does not respond to standard asthma treatment is a red flag and may be due to pulmonary edema. The report also highlighted that orthopnea, chest pain, and exertional syncope are significant symptoms that require further investigation. So syncope during exertion is not physiological, and it suggests an inability to increase cardiac output, which could be suggestive of, for example, pulmonary hypertension. There's also an emphasis on making a diagnosis, a positive diagnosis, rather than just excluding a diagnosis. Moving on to epilepsy, just a few headlines here. And we all know how important it is to counsel women on anti-seizure medication regarding major congenital malformations in pregnancy. We know that lamotrigine, Keppra, and carbamazepine are the safest anti-seizure medications in pregnancy with the lowest risks of congenital malformations. So the European and International Registry of Anti-Epileptic Drugs and Pregnancy is the largest epilepsy and pregnancy registry. And their most recent data shows that lamotrigine at doses of less than 300 milligrams per day doesn't actually confer any additional major congenital malformation risk, which I think is very reassuring for women. The study that I've highlighted at the bottom of this slide is a topic to watch. So a registry study in Scandinavia has found an association between high-dose folic acid, which is what we recommend to women with epilepsy on anti-seizure medication up until 12 weeks gestation to reduce the risk of neural tube defects. And it's found an association between this and an increased risk of childhood cancer. This has very much shocked the epilepsy community looking after women with epilepsy. And one study alone shouldn't yet be changing our practice. We need more research in this area. But it does highlight that we don't know what the optimal dose of folic acid is for women on anti-seizure medication, and that more of a good thing is not always better. So watch this space. The strong message from the 2020 confidential inquiry into maternal medicine, into maternal deaths, was that we need to raise awareness of SUDEP, so sudden unexpected death in epilepsy. 18 women died from SUDEP in a 3-year period. We know that SUDEP is uncommon, but it occurs twice as often in women who are pregnant or up to 1 year postnatal. Most of the women who died had clear risk factors, but had not had risk or prevention measures discussed with them. So in our epilepsy clinic, we've now started screening all women with epilepsy at booking, so we can identify risk factors and counsel women about reducing their risks. So SUDEP risk factors fall into 3 categories. And they can be seizure related, so particularly women who have uncontrolled seizures or have tonic-clonic seizures rather than partial seizures. If women are on ineffective or subtherapeutic treatment, this is a risk factor. And then there can be individual risk factors as well, like living alone and not complying with medication or other adverse factors. So a couple of slides on intrahepatic cholestasis of pregnancy or obstetric cholestasis. So for a long time, ursodeoxycholic acid has been used without an evidence base. PITCHES is a recent trial, it's a double-blind, multi-center randomized trial looking at whether using whether there is a good evidence for using ursodeoxycholic acid. And the trial has found that treatment with ursodeoxycholic acid does not reduce adverse perinatal outcomes for women with this condition. So the primary outcomes of the study were perinatal death, preterm delivery, or neonatal unit admission. And then some further meta-analysis was done from the data, which found that stillbirth risk is only increased when the bile acid concentration is more than 100. We'd usually recommend, or now we would recommend delivery for these women between 35 and 36 weeks. However, women with bile acid of less than 100 can be assured that the risk of stillbirth is not increased until 38 to 39 weeks. So these women can be treated more conservatively. And the recent Green Top guideline on obstetric cholestasis has incorporated this evidence. Just a quick word about cystic fibrosis and a relatively new drug, Kaftrio. It's been billed as a wonder drug. I don't know what your whether you're seeing this in your local population, but we are seeing a sharp increase in women with cystic fibrosis becoming pregnant. Kaftrio is a cystic fibrosis transmembrane conductance regulator, and it contains 3 medications: tezacaftor, ivacaftor, and elexacaftor. So women who are taking this drug have been found to have up to a 10% increase in lung function and significantly reduced lung exacerbations. It's thought that Kaftrio might be impacting female fertility through a combination of direct effects on the reproductive tract and possibly affecting cervical mucus, as well as the significant overall improvement in lung and nutritional health in women with cystic fibrosis. Just a quick word on prenatal testing in haemophilia A and B. So non-invasive prenatal testing is now becoming fairly standard. We can't use it to diagnose haemophilia, but we can use it to offer fetal sex from 9 weeks. And this is proving very helpful to allow carriers of severe haemophilia A and B to access early CVS for prenatal diagnosis and early termination of pregnancy if they wish, if the baby is affected. So if we know early whether the baby is male or female, then they can be appropriately counselled. Women who have a male baby, so 50% chance of the baby being affected, who do not decide to have invasive diagnosis, CVS or amniocentesis, will be offered late amniocentesis, obviously with a much lower complication rate at 34 to 36 weeks if the baby is male. And this helps us to stratify risk. If the baby's not affected, the woman can have a normal delivery in a local unit without any delivery restrictions. And if the baby is affected, then we would recommend caesarean section. Finally, a slide about chronic hypertension in pregnancy. Increasingly, care for women with pre-existing hypertension is changing. This has come out of the Ockenden report, which is a report in the UK about repeated failures in maternity care, and it's highlighted the need for specialist clinics for women with chronic hypertension. It's very important to make sure that women with chronic hypertension are properly investigated for primary causes. There's been an increasing employment of home monitors using technology that can upload blood pressures to the maternal medicine team so that they can provide advice over the telephone. We are using labetalol and nifedipine, first and second line. There's an ongoing study which we're involved in, the Giant Panda study, to work out which is better. And increasingly, we're using doxazosin third line rather than methyl-dopa being used. Placental growth factor is proving very useful in these patients to work out who has superimposed preeclampsia. So finally, it's gone off. Just a last word. We really need to prioritise equity in maternal care. We shouldn't let geography be a barrier for women with complex medical conditions. Thank you.
Thank you very much for your nice talk.
Thank you, Tess. And now we move to the next speaker. I'm glad to introduce Dr. Surabhi Nanda. Dr. Surabhi Nanda, she's a consultant in maternal-fetal medicine at Guy's and St. Thomas Hospital, and she is an honorary senior lecturer at King's College London. She is one of the 2 national fetal medicine representatives for the British Maternal-Fetal Medicine Society. She's going to address us about a very critical issue, which is cancer in pregnancy. Welcome.
Thank you to the organizers for inviting me. Why cancer in pregnancy? And that's because 73% of women die globally from non-communicable diseases, and that includes cancer. But then why cancer in pregnancy? And that's because pregnancy can be a boon, but also a nemesis for cancer. There can be physiological changes in pregnancy which can delay the diagnosis of cancer. Pregnancy non-specific symptoms of cancer can mimic the 3rd trimester symptoms of pregnancy, and so symptoms can be trivialized, so the investigations can be delayed. People may not be comfortable with offering standard treatments which you would offer for cancers outside pregnancy, or even staging and investigations. There could be lack of consensus on treatment, and my personal bugbear, an early recourse to termination or early recourse to delivery just because somebody has got cancer without even considering what are the treatment options available, and a lack of shared learning. So these are 2 cases from the confidential inquiry in the UK, which is a triennial report that is produced, and this covers cancer in pregnancy in one of the reports. The first lady was presenting with persistent symptoms of headache, vomiting, and raised blood pressure. So rightly so, till her postnatal period, she was treated and investigated as preeclampsia. It was only later, with multiple presentations, that she had a CT scan which showed an intracerebral tumor. By that time, it was too late and she died. The second lady, in second trimester, again a very common presentation, comes to the unit with recurrent abdominal pain and has been dismissed quite a few times. Finally, she's investigated for pyelonephritis. They find ascites, and by that time, it's an inoperable cancer and the woman dies. But pregnancy can be an opportunity. Why? Because this is one time where the woman and her family and the healthcare professionals looking after them are quite keen to monitor all symptoms. She's getting regular obstetric and midwifery follow-up. There can be red flag signs that she'll have a lower threshold to report, and she has regular investigations. It is also a time for pre-symptomatic identification of cancer, as you can see here. This case here, the one with the 12-week fetus. This is a recent case that we had. A routine sonographer picks an abdominal, a bladder mass at 12 weeks on a routine first trimester scan. And this is the trajectory. She has a scan at 15 weeks in her local unit. She has a cystoscopy, which confirms or which suspects a transitional cell cancer. The oncologist there suggests termination of pregnancy with cystectomy, with hysterectomy and bilateral salpingo-oophorectomy. But the woman is in her first pregnancy, so the care is transferred to our gynae cancer, to our unit, which is a tertiary unit with gynae cancer services. We then re-staged her, so she had a staging and a recystoscopy. She had an MDT, she had 4 cycles of chemotherapy. We timed her delivery. She got a 38-week delivery with a live baby that is with her at home. And after her delivery, she had a cystectomy with an ileal conduit, and she's doing well. The next case is an incidental finding of a strange report on NIPT, a whole genome NIPT for chromosomal abnormalities in pregnancy at 12 weeks. It comes back with a result which queries maternal cancer. Then she has, the woman had presented with lymph nodes 4 years ago. So she has re-examination. She has a chest x-ray which shows lymph nodes. Then she has a staging CT which identifies a breast mass. And so this woman had concurrent non-Hodgkin's lymphoma and breast cancer in pregnancy. If she wasn't pregnant and if she didn't have an IPT, she wouldn't have had this diagnosis. So this is the distribution of the nature of malignancies in the UK. And like worldwide, one of the commonest malignancies is cancer breast. But in the UK, we have more, the women that have died have also been more those who had colorectal cancer. But why? So this is data from INSIP, which an organization we work closely with, which is an international organization for cancer in pregnancy housed in Belgium. And this is data from their work. Worldwide, the commonest cancer is breast cancer, followed by cervical, followed by lymphoma and ovarian. But if you look at the bar diagrams and the things that I've highlighted, you can see breast cancer, lymphoma, and GI cancers are quite advanced by the time they present. And that's because many symptoms can be trivialized. So that's something to keep in mind. From the confidential inquiries, we found that nearly half of the women that had morbidity or mortality because of cancer were inappropriately staged. As a result, they either received too much or too little chemotherapy. They may have had a different treatment or a different decision about the outcome of pregnancy. So if you look at cancer breast, what is the recommendation from our Royal College? We say that for staging, you can have chest x-ray, you can have liver ultrasound, you can have CT of thorax and brain, you can have, so you won't be doing a CT of the abdomen if she's pregnant, but there's no reason why you can't do an MRI of the pelvis and a skeletal MRI. There's no reason why she can't have a sentinel node biopsy because you will need that as if she was not pregnant in the diagnosis of cancer. And of course, because she's pregnant, you would want to avoid gadolinium contrast. So as a rule of thumb, you should investigate and treat pregnant and postpartum women the same way as you would treat non-pregnant women, unless there's a clear reason not to do so. So this is a brief slide. This is a very busy slide. Just look at, I've already discussed that they can have ultrasound, they can have mammography, they can have CT scan, they can have MRI, even from the first trimester. There was a study in JAMA a few years ago, which said that if you have first trimester MRIs, it can have an impact on the auditory function of the baby or can have miscarriage, but that's not the case. The study has since been refuted. And you can have sentinel node biopsy. You would want to avoid gadolinium contrast because of associated adverse problems to the baby, and sometimes even stillbirth or neonatal death. Let's move on to treatment. So we've established that we can investigate, we can stage, we can image. Now we need to treat. So how do we treat? Now, for 20 minutes, we can't go into details of chemotherapy, but we can stick to the principles. The principles would be multidisciplinary discussions with an obstetrician, maternal-fetal medicine specialist, or an obstetric physician and an oncologist, because there would be chemotherapies that they would use outside pregnancy, but it could be teratogenic. But equally, if she's gone past the first trimester, and if the kind of adverse effect on the baby is just growth concerns or concerns of fluid, then we can probably do that, provided we have done the counseling. Only thing is we will need to do surveillance. So it's individualized care. So you want to maintain the dose intensity. You want to stick to your standard protocols. You want to titrate it to the body weight. Do not increase the dose just because she's pregnant. And the thing that is important is timing the chemotherapy in relation to delivery and then restarting the chemotherapy after delivery. I've had women who have come to me with their calendars and post-it notes to say, this is my first cycle, this is my second cycle, this is my delivery, this is how much I'm going to breastfeed or not breastfeed. What about surgery? So, as a rule of thumb, surgery can be undertaken in all trimesters, although abdominal surgery will be recommended after early second trimester. You can, for breast surgery, usually you will delay the extensive reconstruction after delivery. Most anesthetic drugs are safe, but we will liaise with the obstetric anesthetist. You want to perform a left lateral tilt from 20 weeks onwards, and from 24 weeks onwards, you would want to let your neonates know and offer them steroids. You don't have to have extensive inpatient admissions, but the multidisciplinary team need to know about it. When you're doing abdominal surgery with extensive uterine manipulation, then of course you want to give them tocolytics. You want to give them adequate postnatal analgesia, but also remember that you wouldn't be giving non-steroidals in the first trimester or after 32 weeks because of obvious side effects. And remember, active cancer can cause thromboembolism. So systemic cancer can cause thromboembolism, and you would recommend for any woman with active cancer with or without treatment to be on have thromboprophylaxis from 28 weeks onwards. If she's had surgery, then you have to cover 10 days of the surgical period, post-surgical period, with thromboprophylaxis, and also give them thromboprophylaxis at least 6 weeks after delivery if they have developed any additional risk factors. Now, coming to the other treatments. Radiotherapy. So we would want to avoid pelvic radiotherapy because it causes adverse outcomes. Non-pelvic radiotherapy, it is possible in the first and second trimester, but you will have to have detailed planning around it. And the woman will need supplementary shielding. Immunotherapy, it's a new kid on the block, not for you all as oncologists or gynae-oncologists, but for us in pregnancy. So, and we don't have a lot of data for that. We have a handful of reports, and for those, we know that there's association with fetal growth restriction, but when these small babies have been followed up to 2 to 3 years of age, they have maintained their developmental milestones. And that is the beauty of INSIP. because this is an international collaboration, and for you, I would really hope if you would want to join the international collaboration, because it is an international registry of cancer and pregnancy, which I'll come to in a minute. So, the bane of treatment of cancer and pregnancy in this extremely busy slide is multidisciplinary care. From the time that the woman has a cancer detected, it's all these various specialties, which I'm not going to name in the interest of time, working together to get the best investigations, best treatment, best follow-up care in terms of pregnancy, and not forgetting the psychological support which the woman needs. This charity here in the center is called Mummy Star. I'm one of the patrons for Mummy Star, and it is a non-profit organization which looks after mothers with cancer and pregnancy, and I'll cover that in one of the slides. So, how would you do the surveillance, the maternal fetal medicine surveillance? It's important in the first trimester, if somebody has recently been diagnosed with cancer. I've had a woman who was given the diagnosis of a brain tumor and the fact that she was having twins both on the same day. So it's important to establish viability and diagnose the gestation, because it is well within the right of the woman to have all the options available to her, including termination of pregnancy. Any person who has got active cancer in pregnancy should be referred and seen by a senior clinician, senior obstetrician or MFM in the first trimester, and consider avoiding non-invasive prenatal technique for aneuploidy screening, because it will come up with false positive results. We've already discussed all the treatment and the gestations of treatment. Do they need extra fetal medicine input? Well, if they've been exposed to teratogenic drugs in the first trimester, then I would offer them a detailed first trimester scan, a detailed scan with a fetal medicine clinician and a fetal echo. And I would arrange serial growth scans as we would do on chemotherapy in our unit, because people with chemotherapy also are at a higher chance of preterm labor. So whereas we won't offer cervical surveillance, but we will have a low threshold to do that. We would consider steroids if there's any signs of preterm labor. The aim would be to deliver them 37 plus weeks onwards, and mode of delivery, we'll come to it in a minute. Avoid chemotherapy at least 2 to 3 weeks after the delivery. Postnatally, it's important to have VTE prophylaxis, and important to have an antenatal discussion about whether you're going to breastfeed or not, because that would depend on the chemotherapy washout period, and also how soon you're going to reinstate chemotherapy. Now, the next point is quite important, because if you're not going to give chemotherapy, you would give cabergoline to stop her breast milk. But if you're going to give chemotherapy, you're going to give domperidone to stop her from being sick. Domperidone can engorge her breasts and cause lactational problems. So, choice of antiemetics, or whether how quickly you're going to give cabergoline, those are all important. Neonatally, if chemotherapy has been given less than 3 weeks after, within a baby's born, less than 3 weeks, then needs all these examinations, including hematological examinations and metastatic examinations. If you're on chemotherapy like anthracycline or platinum-based, then the baby needs extra screening. If you're on women who have been on cancer in pregnancy, this is data from INSIP. There's about a 10% PPROM rate, about 1 in 5 will have small babies, and about half will end up in neonatal admission. Majority, if you start chemotherapy early in pregnancy, stronger chemotherapy and a longer duration of chemotherapy, then you're more likely to have a small baby. So as I said, you time your delivery between 37 and 39 weeks, unless the mother is rapidly deteriorating or requiring radiotherapy in the 3rd trimester. Remember, you want to have at least 2 to 3 weeks of washout before you start chemotherapy after delivery. If you've had cesarean section and if you start it quite soon, then that increases the chances of wound adhesions. Mode of delivery can be vaginal, except if you've had an obstetric indication or have a florid cervical cancer, because you don't want, one, it's going to cause labor dystocia, and secondly, there have been reports of lung metastasis in the child. This is sorry, I don't know how to go back now. This is an infographic which we have produced for breast cancer and pregnancy because it is the commonest cancer, and it has been endorsed by Mummy Star. After cancer, you have to wait for at least 2 years before you start of treatment, before you start trying again. And women with metastatic cancers are advised not to get pregnant. And there may be menstrual irregularities if they've had cancer. I can't stress enough about the value of INSIP, and if you would like to collaborate and join, it is Professor Federica Moore in Belgium, or you could contact myself. Mummy Star is an international charity. It just supports women and families who have got cancer in pregnancy up to in the last 12 months. Whereas it can offer financial support only in the UK, but they will offer psychological support or peer support for anyone across the world. APSIP, I can't finish a talk on cancer and pregnancy without talking about APSIP. It is an advisory board for cancer and infertility, pregnancy and infertility. It is free of cost, and if you write a question, within 7 days you would get an advice by MDT clinicians like we've just mentioned. So in conclusion, cancer and pregnancy is not an obstetric emergency. There's time for deliberation and second opinion. Pregnancy is not a contraindication for staging or sentinel node biopsy. Be prepared for preterm delivery in small babies. Termination of pregnancy does not improve the outcome. Equally, cesarean does not improve the outcome. Multidisciplinary team work, third sector support for supporting the families is important, and pregnancy is a time for shared learning and collaborative work. And I'll leave you with a quote from one of the ladies who we looked after and has got support from Mummy Star, that I still find it hard to fathom that the body in the same place and the same time that it created and grew a new life was developing something that can kill me too. And I thank my collaborators and the organizers for their invite. Thank you.
Thank you very much, Dr. Nanda, for your informative talk, and thank you. The last speaker from our international speakers come from Sheffield, will be presented by Dr. Stephen Stratton. He is a consultant of obstetrics and fetal medicine in Sheffield. He is the main investigator of the randomized controlled studies and research projects aiming to women's health.
Thank you very much. Good morning, everybody. So I've got 20 minutes to go through the big subject of fetal growth restriction. And I think premature birth is one of the most important things that we deal with. It has the biggest impact for mortality and morbidity in our neonates and for our families. And what we're talking about with fetal growth restriction is iatrogenic preterm birth. So we have to manage the preterm birth to get the best outcomes. And that's what managing fetal growth restriction is all about, to improve the outcomes. Just a word, I've got this slide twice, just to hammer it home, that preeclampsia is a placental dysfunction. Fetal growth restriction is placental dysfunction. Okay? Okay. Thank you. So absolutely look at the fetus when you see fetal growth restriction, but don't forget the mum, because mum could have severe preeclampsia, and we would deliver mum with severe preeclampsia if she had severe preeclampsia, despite what the baby's doing. So back to the very beginning of what we need to do to improve our outcomes, particularly in relation to fetal growth restriction, is our risk assessment. Now these are two examples of risk assessment. They're very similar. They've been around for about 60 years and relatively unchanged. More and more over the last few years, we're getting more research about different ways that we can reassess people and get more accurate measurements. If we use the older risk assessments, 1 in 4 of our women will be of a higher risk category. And that means we're telling lots of women that aren't at risk that they're at risk. They then don't comply with their aspirin. They don't do the things that we need them to do to improve their outcomes, and therefore we have worse outcomes. There's some research coming up on that a little bit later. But we know that the risk factors are not equivalent. So if you take age of 40 and primary gravida, those risk factors are completely different. But yet in the tick box, we treat them as exactly the same. Categorical evaluations of risk is really important. So if I'm at risk at the age of 40, why aren't I at the risk at the age of 39? Surely I am still at risk, but particularly in the UK, we draw a line between high risk and low risk, and we shouldn't be doing that. I've talked about the cumulative effects of different things in the same thing, but also protective factors. So if I am younger, or I have a normal PAP-A, does that actually mean I'm at less risk, and therefore my risk assessment decreases? A big slide that I'm going to talk about is ethnicity, and particularly in the UK, by including ethnicity in our risk assessments, particularly for Black and Asian women in the UK, we can improve their outcomes because the tick boxes that I showed you before do not include ethnicity as a risk factor. So we know the other risk factors, and we should be including these in our risk assessment. So blood pressure, using the number, not just a level of high and low risk. The uterine artery Dopplers, lots of studies that these can predict who's going to suffer from fetal growth restriction, and then your biochemical markers for the placenta. So, what do we do in Sheffield, and what's becoming more popular is we use the Tommy's app, which is on the right of this screen. Essentially, it's based on the Fetal Medicine Foundation, which is free on the internet, and you can put all the demographic risk factors for mum, you can put the uterine artery Dopplers, you can put your biochemical, and it uses artificial intelligence to give us a much more accurate assessment of the risk. And if we do this, we actually get the women who are going to suffer from fetal growth restriction, not a random spread of people, then we can make the right interventions and we can improve their outcome. And this slide shows that actually we reduce the amount of people that develop preeclampsia, which is also placental dysfunction, prior to 37 weeks. And if we do that, we improve the outcomes. And then looking at the ethnicity, which is actually using the Tommy's app that we use in Sheffield, that if we use ethnicity in our risk as well as everything else, this is one of the only interventions that we found that can actually equalise care between Black, Asian versus white women. So we absolutely should be using an algorithm, ideally with artificial intelligence, so that we can improve outcomes because we can intervene before fetal growth restriction even takes us. Alas, my talk is all about the investigation of fetal growth management. So we're going to spend the next 10 minutes just talking a little bit about that. In 2013, and then revised shortly later in 2014, our Royal College produced this guideline, which I think every single obstetrician has an issue with this guideline. It's the most controversial of all guidelines, with the most comments that were made to it. The new guideline, thank goodness, is due in 2022, and if we look at the date today, we know that we're vastly overdue for that, which just adds to the complexities of what we're going to discuss in terms of making guidelines around what the right thing to do is. One thing that we can agree on is the definition. So we've had the Delphi consensus, which talks about what fetal growth restriction is, and essentially it's a baby that's below the 3rd centile at any gestation. We arbitrarily divide this between 32 weeks and below and 32 weeks and above, and then we have different criteria for them. The criteria for 32 weeks and below is actually really specific, and we've got really good, from the Truffle study, which I'll go into, ways to detect and manage these patients. However, late, just from the pure, that there's more numbers on this slide of how we actually define it's a bit more difficult, and that is the challenge. How do I define late FGR that's going to cause a problem? So, we'll talk a little bit about that, but before we go on, we're going to talk about, is it fetal growth restriction? So in March 2023, this year, a study was released in the UK. When we have a small baby with growth below the 3rd centile at 20 weeks, we often offer amniocentesis to look for chromosomal abnormalities. We then do a microarray to look at further chromosomal duplications and deletions. But actually, if we send these samples off, so this is a baby that has no other abnormalities, it's just small, we think it's placental growth restriction, but if we send them out for a whole exome sequence, about 12% of them will have a monogenetic problem. So we need to be thinking about, is this growth restriction? Not everyone will have an amniocentesis, so we need to use placental growth factor. If we see a small baby and we have a normal placental growth factor, then we need to absolutely be thinking about a different cause. But they can be normal, so just be aware of that. This is a classic slide of what actually happens, just to say that we all know that in fetal growth restriction we have remodeling of the distal uterine artery branches. It's narrower, we have an abnormal trophoblast, and then we develop abnormal Dopplers. Beware of the umbilical cord Doppler. Around the world we still use, and in most centres in the UK I believe, end diastolic flow positive is good, so that baby is safe. But remember, after 32 weeks you can have end diastolic flow in a baby that is severely compromised with fetal growth restriction. This is a really busy slide, but this is probably one of the most important slides just to summarise the talk in total. So when we look at fetal growth restriction before 32 weeks, we're talking about how do we manage these babies. We can see the Doppler changes. As a fetal medicine specialist, we love the Doppler changes. We love doing an umbilical artery, we love doing a ductus venosus, an MCA. We absolutely see the changes, and we know how to manage them and monitor them thanks to the truffle study. At the bottom, we have fetal growth restriction, and this is late fetal growth restriction. And this is where it becomes a little bit more challenging, because we can have normal Dopplers, we can have normal ductus venosus, we may have reduced resistance in the MCA Doppler, but we may not. So it becomes much more challenging, and that's where us, as experts, and the research need to help us to decide what to do. But at the moment, it's about us being the experts and the scanners that can do all these things. Note in these slides, early 70% hypertensive disorders, and at the bottom 18% hypertensive disorders. So there is a massive increase in the risk of preeclampsia. Do not send a woman to my clinic with severe preeclampsia that needs delivery for severe preeclampsia that has absent end diastolic flow at 34 weeks, because I'll say I don't need to scan her, save the woman and deliver that baby. So just always remember, if you see fetal growth restriction, think it's placental dysfunction and what other consequences are they going to be. So, you've all read the truffle study if you're fetal medicine specialists. We all know the principles of this, which is that ductus venosus, reversed A wave, is an indicator for delivery. And we love doing Dopplers, as I've already said, in fetal medicine. However, the safety net for doing this is the CTG, and it has to be computerized. So everybody now in a fetal medicine department should be having a computerized CTG analysis, looking at the short-term variation, which you cannot see with your eyes, and looking for repeat decelerations. Over 50% of people in this study were delivered because of the CTG with a normal ductus venosus Doppler. So you absolutely have to use both. So what do we do? The truffle study doesn't really say how often you do these things, but in Sheffield, if you're below 32 weeks, we will scan you 3 times a week. I put ductus venosus and umbilical artery Doppler as the most important things, but obviously we look at the MCA, obviously we look at the fluid around baby, and obviously we look at baby's growth to make the decisions about what we do. After we've done a scan, we do a computerized CTG, or we can do it beforehand, and then we make a decision about whether that baby needs to be delivered. In our hospital, we get sent people who have had absent end diastolic flow, and we give them steroids, and then they come to see me, and I can prolong their pregnancy for, say, 25 days. The steroids to improve fetal outcome are most effective within 7 days. So if I use that technique, I have missed an opportunity to improve the outcome for baby. And when we're looking at fetal growth restriction before 32 weeks, this is the preterm birth mortality and morbidity that I was talking about at the very beginning. And this is how we reduce that by prolonging the pregnancy and optimizing the care of the fetus once it's born. As obstetricians, we absolutely need to work with our neonatal colleagues. These babies absolutely need to be born where there's a neonatal intensive care unit, and we know the strategies. But maternal breast milk is something that we are making more and more improvements with. But remember, if you've got a woman who you think you might be delivering in the next 7 days, you can give them steroids. You think about magnesium a lot closer to delivery, but give her a pack to start expressing milk and support her to do that. Because if that baby gets colostrum in the first few hours of life, we will improve the outcome for the baby, for the family, and that's what this is all about. So don't just think about your scans, think about your neonatal colleagues as well. Obviously, caesarean section. In Sheffield, we do lower transverse incisions. We're very successful at that. We very rarely do classical incisions. All these babies will need to be born by caesarean section, and all these babies are premature. So the difficult one, very hard to compose a slide, and I've done it in one slide, but it's a much bigger topic, late fetal growth restriction. You'll see that there's no study or slide on this one, because the challenge is a diagnosis. If I see a baby less than the third centile, do I think there's fetal growth restriction? Yes. By definition, that baby has fetal growth restriction. But do I need to deliver that baby is a much more challenging question. Because we know the management's easy. When we can diagnose that that baby is severely compromised, we organise a delivery. However, when do we need to make that decision is much, much more challenging. There's more and more evidence to look at CPRs or the MCA Dopplers. And absolutely, if there's an abnormality in that, that's a sign to deliver baby. But if it's normal, are you confident to go on, is a much bigger question. We use the umbilical artery Doppler. We don't say end diastolic flow positive. We look at the actual pulsatility index so we can tell whether it's normal or not. CTG, I don't think there's any good evidence at the moment for using it, so we don't use it unless there's a history of reduced fetal movements. And what you're seeing is I'm saying unless, maybe, if this happens. And what we actually do in Sheffield is we do lots of scans, and it tends to get referred to the fetal medicine doctors, but because we can't, this is a big problem with lots of people, it's difficult to scan everybody. If you're in a situation where you can, then it's much easier, but you have to use your brain and use everything that you've got in your armoury. And people will ask me, well, how do you know? And the answer is, I don't know, because it's an individual assessment of that woman. If there's absolutely no growth, if there's declining fluid, if there's an abnormal MCA, we'll be thinking about delivery before 37 weeks. But you've got to make these decisions. Talk to your senior fetal medicine doctors about how we actually do this. There are some absolute indications, but it's really, can this baby continue? And what we talk about in Sheffield is not how is the CTG, how are the Dopplers. What we talk about is this baby safe to continue inside mum before we need to cause delivery? The management is easy, we cause delivery. If you have got, now I've told you not to listen to positive end diastolic flow, but if you do have positive end diastolic flow, we offer induction of labour, not caesarean section, but obviously that will need to be continuously monitored with a CTG in pregnancy. My slides aren't moving on. I think it's a summary slide next. Oh no. One of the other frequent questions that come to me is the different charts that we use. We've recently introduced a different, so we've gone to Intergrowth 21 in Sheffield, and we've moved away from Grow charts, which are different charts, but we know just from that simple move that one baby can be above the third centile and not have fetal growth restriction, and one baby can absolutely be below the third centile and have fetal growth restriction. This is a really interesting slide, and what it tells us really is, in terms of outcomes, there's not much difference, but the most important thing is in your hospital, choose something, use it, and stick with it, and use it for all your populations, and look at your outcomes. The reason why we've changed to Intergrowth 21 is because that's compatible with the assessment that we do at the first trimester, the fetal growth restriction using the Tomizat. So, placental growth factor, this is just one of the biochemical markers that we've been talking about in academic conferences like this for years and years and years. We know it has a role, so we should absolutely have hospitals that can measure it. I've already mentioned it in the use of the risk assessment in the 12-week scan, at the 12-week time. We can use it to confirm placental causes rather than a genetic cause to help us with a diagnosis. Our NICE guidelines now use it for preeclampsia, and we know that preeclampsia is also placental dysfunction. So if our placental growth factor is saying this woman has preeclampsia, we need to look for fetal growth restriction as well. There's more and more studies coming out showing that abnormal placental growth factors have bad outcomes for baby. That's not really useful to me as a clinician in the clinic, because it doesn't tell me when do I need to deliver baby. I know that people that have severe preeclampsia need to be delivered anyway. And we're absolutely waiting for that RCOG guidelines, but I wonder if they publish it again, is it going to be one of the most controversial things that we ever do? So just a quick summary before I finish. So absolutely, fetal growth restriction starts with your excellent risk assessment. Then you can intervene with aspirin and other things. You can focus your attention on the people that need it, and you can absolutely improve your outcomes. Early fetal growth restriction, we know a management technique for that as per Truffle, but don't forget fetal optimization. So you're thinking about your steroids, your magnesium, express breast milk. We do delayed cord clamping for all of our babies that are under 32 weeks. They have a minute attached to mum on the cord. So we do all these things to absolutely optimize these babies, because that's the most important, or one of the most important things for neonatal outcomes. And then late FGR is a bit of a minefield. Use a consistent diagnostic criteria and use your colleagues, your brain, your expertise, your scanning hands to make good decisions about when to deliver these babies to provide the safest care. Thank you very much. Thank you very much.
If you allow me, I will ask one question. In 1982, I finished my PhD in ultrasound about the diagnosis of biometric and assessment and dynamic assessment of fetal growth retardation. And since that time, all the research is concentrating on how to diagnose and when to terminate. But I wonder why there are no trials to implement some sort of medical therapy to help to prolong pregnancy and to avoid the hazards of intrauterine growth retardation. Are you aware of any research work that is directed to the treatment of IUGR?
Sorry, it's how to prolong the pregnancy.
How to improve the outcome by introducing some medical or chemical or whatever to improve the growth of the baby while in utero. We have a piece of research done by our late Professor Mahran about the use of solcogeril to improve the, and there were positive results about this material, but since that time there is no further research in this field.
I can't really hear the question, sorry. Okay. Can you hear it? I probably did hear your question, I've just never heard of it. the intervention that you talk about. So we don't use it in Sheffield. Solcosterol. No, we don't use it. The biggest thing that we were always told about is delivering babies at 34 weeks. We usually have a normal mortality for babies that are delivered at 34 weeks. But there's more and more evidence that past 34 weeks, 34, 35, 36, each week that goes by improves outcome. So if there is anything out there that can do that in terms of prolonging the pregnancy, that's what we need to do to improve fetal outcomes. So actually, if you've got an intervention that prolongs the pregnancy, then that would be the best thing that we could do. Sorry about that. Sorry.
Thank you so much. Thank you, Professor Statson. Now we will move to Bayer Symposium. Professor Abdulatif Al-Kholi is to give us a talk on antenatal supplementation when innovation meets patient needs. Professor Abdulatif is Professor of Obstetrics and Gynecology at Ain Shams University. He is one of the leading figures at our department, and we are waiting for this talk.
Thank you, Mr. Chairman. صباح الخير جميعا. First of all, I'm really honored to be presenting a talk in the prestigious ASOGIC conference of Ain Shams University, Department of GYN. Today's talk will address the use of antenatal supplementations. What's new? Antenatal supplementations have been here for decades. ومفيش حد ما بياخدش antenatal supplementations. They really vary over time, and we have to know what's the idea behind giving supplementation. Why do we give? What exactly do we need? Do we write because of the patient's pressure? Do we write because the patient really needs? We'll discuss a brief idea about the antenatal supplementations. This talk is sponsored by Bayer Consumer. We'll talk about the modern food trends which led to the fact that we need to administer antenatal supplementation, the current concepts of multimineral supplementation, and the new era of omega addition to the supplements. Do we really need it, and why do we need it right now, or we don't need it at all? So first of all, do we really need supplementations? الناس طول عمرها بتاكل وبتشرب كويس وبتتغذى تولد اطفال كويسين. هل احنا دلوقتي في حاجه مختلفه محتاجين عندها supplementation؟ يعني في حاجه اتغيرت في الدنيا makes us need further supplementation because there is a change which happened over the past few decades. الحقيقه مايكل جيكوبسون one of the activists in the field of nutrition. حتى هو عمل center for nutrition and health، والمين تارجت بتاعه او الاوبجكتيف بتاعه كان ان هو بيحارب المودرن فود ترندز. حتى هو كان من ضمن المسميات اللي اتقالت الجانك فود او فود بورن، بيلقب ب the new trends of eating habits which are present nowadays. المشكله انه الجلوباليزيشن اند urbanization مش دايما بتجيب الحاجه الكويسه. للاسف الفود ترندز اتغيرت، بقى في جانك فود كتير جدا، الكوميتمنتس بتاعت الناس للشغل بقوا تقريبا all day long موجودين بره البيت، and that's why الجانك فود يوز بقى كتير جدا، والهيلثي فود ادمنستريشن او انتيك بقى قليل جدا، and that led to the concept of the empty calories. الناس بتاخد كالوريز قد كده، بس الكونتنت اللي جواها is lacking the essential elements، وبالعكس بيبقى غني جدا في الساتوريتد فاتي اسيدز، بالريفايند شوجرز، بالوايت فلاور، بالحاجات اللي فيها هاي سولت كونتنت. ايفن حتى هو عمل كتاب اسمه السولت وور بيقول فيه ان هو بيحارب الهيئات الامريكيه اللي مش قادره تقف قدام الجانك فود، والاندستري مش قادره تبطلها او تقف قدامها. الفود بروسيسنج الحاجه الثانيه، غير كمان الكواليتي اوف فود والترندز بتاعت الحياه بتاعتنا، كمان الفود بروسيسنج اللي ابتدى يبقى موجود. الناس كلها بتشتري فود اون ذا شيلف، نادرا ما حد بيجيب دلوقتي اكل طازه. الفود اون ذا شيلف ده في البروسيسنج بتاعه ايا تكون الطريقه بتاعته بيلوز a lot of its content of vitamins. يعني الديجرمينيشن مثلا بتاع الميز بيضيع تقريبا نص الفيتامينز اللي كانت المفروض تبقى موجوده. والنقص في الفيتامينز ده is not only confined to the third world او to the developing countries، كمان ال developed countries ال attitude of food in the western countries بتخلي فيه prevalence of nutritional deficiencies in even the western countries. طيب ليه بقى السبلمنتيشن هتأثر في البريجنسي؟ يعني pregnancy is an important era in the future life of the baby, of the child, of the youth, of the man او of the woman، لانه بتبتدي من وهو صغير الافكشن of the baby intrauterine، الفيتال environment will affect the further development of the baby. وده كان الباركر هايبوثيسيس لما كان ديفيد باركر assumed ان في حاجه اسمها epigenetic effect بتاثر على الامبرنتنج بتاع الصفات الوراثيه اللي اوريدي موجوده جوه الطفل. يعني هو مش مولود بحاجات وراثيه موجوده مش هتتغير، ممكن تتاثر بالظروف الخارجيه. وطبعا اصدق مثال على كده كان الورلد وور 2. كان وورلد وور 2 كان في الداتش فامين، هو الحرب عملت شغل جامد كده. الداتش فامين لقوا ان الاطفال اللي كانوا مولودين في الوقت ده suffered from severe nutritional deprivation عشان المجاعه اللي كانت موجوده في هولندا، واكتشفوا ان الاطفال دي على قد ما كانوا اطفال مولودين جروث ريستريكتد وصغيرين، بالعكس بعد كده في الادوليسنس والادلتود ديفلوب سيريس هيلث ايشوز. اولا جزء منها كبير قوي related to the pancreatic affection، ابتدى يجي لهم diabetes type 2 diabetes، ابتدى يجي لهم atherosclerosis coronary heart disease. They tended to die earlier than their counterparts born everywhere else. ولقوا ان دي كلها مشاكل نبع من التعرض لظروف deprivation in utero خلت يحصل بعض الميكانيزم او الابيجيناتيك ميكانيزم اللي ياثر على الفيرذر ديفلوبمنت. هياثر ازاي؟ يعني هي جينات ايه الميكانيزمز اللي ممكن ياثر بيها؟ First through the DNA methylation and genomic imprinting. Second through the non-coding RNA sequences. ثالث حاجه الريسبتور دنسيتي نفسها، الفوليوم نفسه بتاع الاورجن ممكن يتغير، الاكتس اللي موجوده ريسبونس تو ستريس، يعني الكورتيكوتروبين ريليزنج هرمون بيتاثر، الهايبوثالاميك اكسس بيتاثر، وممكن يبقى الاطفال دي عندها ستانتد جروث ويبقوا اوبيز في نفس الوقت. واخيرا الاندوثيليال ديسفانكشن كمان ممكن ياثر على الديزيزز اوف ذا اثيروسكليروزس اند كورونري هارت ديزيز. طبعا زي ما انتم حضرتك شايفين ده الاساس لما مخوخ، دي عماره كامله اللي انهارت في الزلزال. اساس لما يبقى ضعيف بعد البنى مهما حاولت تحسن فيه عمره ما هيتحسن. And that's why the window of opportunity, which was the first 1,000 days in the life of the baby, will affect greatly the health path the baby will take during his life. 365 يوم طبعا الاولانيين في حياته السنتين، وال 270 يوم and that's the 1000 day journey. طيب نقيس للناس الفيتامينز ونشوف هل هم محتاجين ولا مش محتاجين، بدل ما ندي على الفاضي. المشكله انه الفيتامينز لازم تبقى القرايه فيري هاي او فيري لو عشان تقول ان في ديفيشنسي. الحاجه الثانيه ان في فاكتورز ثانيه ممكن تاثر زي الجينيتك بوليمورفيزم. وي اول هاف ويتنسد ذا اير اوف فيتامين دي. انا ما اعرفش راي حضراتكم ايه، بس الفيتامين دي فجاه طلع وفجاه كل الناس بتقيسه وفجاه كل الناس عندها ديفيشنسي وفجاه بيعالج كل الامراض. ما حدش قال ان الرقم ده هو الرقم الناقص. الجينيتك بوليمورفيزم ممكن يخلي ال 30 ده النورمال بتاعي، ممكن يخلي 20 بالنسبه لدكتور كرم، ممكن يخلي 100 بالنسبه لحد تاني. فطبعا قياس نسبه الفيتامينز مش هو الحل الوحيد اللي نعرف بيه اذا كان في ديفيشنسي ولا لا. طيب ايه الجديد اللي ممكن يحصل في الفيتامينز؟ حضراتكم شايفين، حد عارف دي عربيه مين؟ ده عربيه ماكس فيرستابن، يعني الليجند بتاع الفورمولا 1، ودي عربيات الخمسينات في الفورمولا 1. هي نفس العربيه، هم نفس الفيتامينز، بس الحاجات بتتغير. طيب هل احنا محتاجين فعلا اوميجا؟ need to add omega inside the vitamin supplementation. اكيد حضراتكم في العيادات بتلاقوا بريشر جامد جدا من البيشنت اللي جايه، غالبا هي اللي بتيجي يا واخده اوميجا يا بتطلب الاوميجا يا بتسال عليه. وممكن جدا لو حضرتك ما كتبتوش تيجي الزياره اللي بعديها تقول انا بعت جبت من بره فيتامين او انا خدت اوميجا زياده. ليه الكونسيبت بتاع الاوميجا ابتدى يطلع اليومين دول؟ وهل احنا فعلا محتاجينه ولا ده حاجه فانتازيه اضافيه؟ هل نديه لسبيشال هاي ريسك جروبس؟ هل نديه في انديكيشنز معينه؟ هل ما نديهوش خالص؟ هل نشوف نديفيدواليز البيشنت، نشوف مين محتاج فعلا ومين مش محتاج؟ ناخد ندرس العادات الغذائيه بتاعت كل واحد ونشوف اذا كان محتاج ولا لا. نشوف الاوميجا. اولا طبعا الحاجات اللي احنا بنتكلم عليها الاوميجا 3 and 6 بولي انساتوريتد فاتي اسيدز، واللي يهمنا جدا هو الاوميجا 3. الاوميجا 3 الموجود هو ثلاث حاجات اللي هو بتسمعوهم دايما الاي بي اي والدي اتش اي، اللي هو الايكوزا والدوكوزا هيكزا اينويك اسيد، والالفا لينولينيك اسيد اللي هو بيبقى موجود اكتر في الفلاكسيد اويل اللي هو اكل الغلابه الزيت الحار. وهنشوف دلوقتي هل ينفع نعوض ده مكان ده ولا ما ينفعش نعوض ده. طيب ايه اهميه البولي انساتوريتد فاتي اسيدز اللي هم الاوميجا 3؟ الاوميجا 3 ميزتها ان هي بتخش في الفوسفوليبيد بايلير، يعني هي موجوده في كل خليه موجوده في جسمنا، وكمان بتخش في البروستاجلاندين باثوي بتاع السينثيسيس. دي وظائف مهمه. حضراتكم عارفين البروستاجلاندينز موجود منها حاجات عكس بعضها، يعني ممكن نلاقي بروستاجلاندين ده دايليتور، ممكن نلاقي بروستاجلاندين ده بالعكس فازو كونستريكتور. ثرومبوكسين يعمل بليتلت اجريجيشن، بروستاسايكلين يقلل بليتلت اجريجيشن، وبالتالي الباثوي اللي هيمشي فيها التصنيع هتعتمد على ايه؟ هتعتمد على المتواجد في جسمي. هل انا موجود في جسمي ما يكفي من الدي اتش اي والاي بي اي فامشي في طريقه تصنيع الانتي انفلاماتوري بروستاجلاندينز، ولا مش موجود فهيبقى اوفر كام بالعكس اللي انا مش عايزه. الكونسنتريشنز طبعا بتاع الاي بي اي والدي اتش اي بتحول البروستاجلاندين سينثيسيس towards الليس انفلاماتوري سايد. الالفا لينولينيك اسيد طبعا جميل وحلو، موجود في الوالنت وموجود في كمان الفلاكسيد اويل، بس المشكله بتاعته انه الكونفرجن بتاعه بيبقى مينيمال، بالكتير قوي من 1 ل 10% بيتحول للاسنشال اللي احنا عايزينهم اللي هم الاي بي اي والدي اتش اي، وبالتالي هو ما ينفعش كبديل. ان طلع وقت من الاوقات قالوا خدوا زيت بذره الكتان وده مايت ريبليس الاوميجا 3، لا الحقيقه انه التحويل بتاعه اضعف من ان هو يقوم بالغرض. طيب في البريجنسي الاوميجا هيبقى مفيد بالنسبه لنا في ايه؟ يعني واي دو وي نيد اوميجا ديورينج بريجنسي؟ الفيتس بيأكيوميليت الاوميجا مينلي في الثيرد ترايمستر، وبيبقى اسينشال في الجروث بتاع النيرفس سيستم. احنا ما اتكلمناش لسه هل في ديفيشنسي ولا لا، هنتكلم هل له رول ولا لا. الاوميجا المفروض ان هو بيبقى هايلي كونسنتريتد في النيرف سيلز بتاعت البيبي، في الجراي ماتر، في الريتينال ابيثيليوم، وبالتالي هو مهم في الديفلوبمنت بتاع الاي والبرين بتاع البيبي. الترانسفير بتاع الدي اتش اي والاي بي اي بيبقى اكتر في الثيرد ترايمستر، وكمان الاي بي اي بيفاسيليتيت الدي اتش اي ترانسبورت للبيبي اللي بيحتاج تقريبا 50 ل 60 مللي جرام بير داي ديورنج الثيرد ترايمستر. وزي ما اتفقنا هم بيحودوا او بيشفت السينثيسيس بتاع البروستاجلاندين towards a less inflammatory site، وبالتالي they are theoretically going to decrease the inflammatory pathways which are happening during pregnancy in the patients who develop preeclampsia for example. وزي ما قلنا برضو الاندوثيليال ديسفانكشن بيبقى ليها دور في هذا الموضوع، الالرجيك رياكشن في البيبي، والبريتيرم بيرث بما انه الولاده is an inflammatory process، وبالتالي if we decrease the inflammatory process we might prolong pregnancy. الكلام ده كان بيتقال قبل كده وكنا ساعات نقول صح وساعات نقول غلط. هل احنا بقى عندنا evidence ان الكلام ده يبقى مظبوط؟ هنشوف الكلام ده. هل احنا ممكن نوفر للناس الاوميجا من غير ما ياخدوه سبلمنت؟ ممكن ناخد الفيش المارينز هم الحاجه اللي فيها هاي سورس اوف اوميجا 3، وممكن ان احنا نوفر للناس 2 to 3 servings of fish every week. The problem with the fish will come with the mercury, the methyl mercury, which might be neurotoxic, and that's why لازم ننزل الليسته بتاعت الامريكان فود اند اجريكلتشر ونشوف نوع الاسماك ونشوف جاي من انهي بحر ونشوف الكونتنت بتاع الميركوري قد ايه، واذا كان العينه فعلا ممكن تاخد منه 2 to 3 servings كل يوم ولا لا، وده الحقيقه از بيج هيدك. تاني حاجه مش كل الناس بتحب المنتجات السمكيه سواء عشان سعرها سواء عشان الافيلابيلتي سواء عشان التيست، وبالتالي ان انا اخلي العيان اعتمد ان هو هياخد الريجولار انتيك بتاع الاوميجا في الفود ده غالبا مش هيحصل. البنفيتس اللي احنا اتكلمنا عليها بنلخصها: الايفكت على النيورو ديفلوبمنت وذر الريتينا او وذر النيرفس سيستم، possible ريدكشن في الانفلاميشن associated with allergy والاتوبيك ديزيزز، ريدكشن في الانفلاماتوري بروسيس اوف بريكلامسيا، بيقلل طبعا الهازاردس ليبيد بروفايل، وهنيجي دلوقتي نشوف الاف دي اي قالت ايه مؤخرا، بيقلل في بعض الدراسات الديبريشن وذر ديورينج او البوست بارتم ديبريشن. الكوكرين ميتا اناليسيس في 2018 رجعت دراسات كتير جدا وقالت انه فعلا الاوميجا كونه بيدايركت الانتي انفلاماتوري باثوي اوف بروستاجلاندين سينثيسيس، فهو بيقلل الانسنس بتاع البريتيرم ليبر، الفيري بريتيرم بيرث، وكمان اللو بيرث ويت، ولقوا ده ينطبق على قبل 37 بيقل وقبل 34 بيقل. ايفن سام ترايلز راحت ان هو مايت برولونج بريجنسي اب تو 42 ويكس. فالكوكرين معترفه ان ده الحقيقه بيحصل. طب السبلمنتس ايه ميزتها عن ان انا اعتمد على الجزء الغذائي لو انا خايف من الميركوري؟ لان طبعا الحاجات السبلمنتس تبقى بيوريفايد، يعني ما بتتجابش زي ما هي كده تتحط، تبقى بيوريفايد من سلالات معينه، وساعات بتبقى بروديوست في الالجي في بعض الاحيان عشان ما تكونش ملوثه بالميركوري خالص. ده اول حاجه. بس المشكله on the opposite side ان هي ليها ساعات some side effects. يعني الاوميجا ساعات بيعمل اودر، ساعات بيعمل بيربنج، الناس تتكرع كتير، ساعات بيعمل دايريا، ساعات بيعمل جي اي تي ابسيت، بيعمل باد اودر اوف ذا بريث، هارت بيرن، ريفلكس. فالحقيقه ان هو السورس اوف اوميجا والكومبوزيشن والبيوريتي بتاع الاوميجا والدوزنج ستاندردايزيشن از امبورتنت علشان ما يؤديش الى سايد افكتس، بالذات لو ان احنا هيبقى اوريدي البيشنت ساعات في اول الحمل بيبقى عندها جزء من النوزيا والفومتنج. ذاتس واي احنا مش بنتك قوي على ان احنا لازم نادمنستر الاوميجا في بدايه الحمل، ان احنا قلنا انه بيبقى كونسنتريتد في اخر ترايمستر ديورينج بريجنسي، فبالتالي ممكن اسكيب الفتره الاولانيه اللي العينه بتبقى فيها نوزيتد وبعدين ابتدي ادمنستر بعد كده. ريكومندد انتيك بتاعنا قد ايه؟ المفروض ان هو الديلي سبلاي يبقى 200 ل 300 مللي جرام بير داي. طيب هو هاو فار از ات سيف؟ ممكن في ناس تاخد 500 1000 اتس سيف اب تو 2 جرامز بير داي، بس ريكومندد ان هو يبقى كافي يبقى 200 ل 300 مللي جرام في اليوم. طيب ما ندي الاوميجا ده في صوره كود ليفر اويل، ارخص متوفر سعره قليل. مشكله ان هو بيحتوي على فيتامين اي بجرعات عاليه، وزي ما حضراتكم عارفين فيتامين اي ده مش الشيطان، هو فيتامين اي ده اسينشال في البروجرامينج، لكن الكتر بتاع الفيتامين اي ممكن يؤدي الى بعض المشاكل في السي ان اس بتاع البيبي واوروفيشال مالفورميشنز. عشان كده بنتجنب ان احنا نستخدم الكود ليفر اويل كسورس بتاع الاوميجا بتاعنا، وبنفضل المارين سورسز بتاع الاوميجا. طيب ايه الايديال بقى بريباريشن اللي انا هحب ان انا ادمنستر للبيشنت؟ اول حاجه هعمل بيشنت سelection. هل العيانه دي هاي ريسك؟ يعني العيانه دي عندها انفلاماتوري بروبلمز، عندها اثيروسكلوزس، عندها هارت ديزيز، هايبرتنسيف، جالها بري اكلامسيا، اي جار قبل كده، عندها بري هيستوري اوف بري تيرم ليبر، دي عيانه ديفينتلي اي وود سيلكت ان لازم هديها اوميجا. اذروايز انا ممكن اسال العيان هل هي اوريدي عندها ما يكفي من الفيش سورسز موجوده تكفي الريكوايرمنتس اليوميه 2 to 3 meals a day a week، ومتاكده ان هي ما فيهاش نوع contaminated بميركوري. يعني that's something we have to inquire about. ممكن يبقى اسهل لي ساعات ان انا ادمنستر امبيريكال الاوميجا. طب الريشيو بتاعي قد ايه عشان اعرف اقرا اللي انا محتاجه؟ 2 to 1. يعني المفروض الدي اتش اي للاي بي اي تبقى 2 to 1. المفترض ان هو يبقى less in side effects. المفروض ان هو يبقى ملوش تيست، ملوش افتر تيست، ما يعملش جي ار تي سيمبتومز. الاسهل طبعا لما يكون all in one، يعني instead of the patient swallowing 2 products together، او instead of the patient forgetting one، او بتاخد واحد ما بتاخدش الثاني، يبقى it's much easier to administer all.
Thank you very much, Professor Abdul Latif. I would also like to thank all our distinguished guest speakers, and we now move for the opening ceremony.